Hello, everybody, and welcome to today's webinar on Phlebolymphedema. This is Tony Gasparis. I'm the Chief Medical Officer for Tactile Medical, and this is a webinar put together by Tactile on Phlebolymphedema management and new therapies and new technology. So with us today, we have Christopher Compton, who is a vascular surgeon out of Tucson, Arizona, as well as Steve Elias, who will be co-moderating with me today's webinar. Just a reminder, any Q&As, please put in the box at the bottom, and we'd like to make this very interactive. So throw your questions at us, and we'll answer them live as the webinar is going on. And we are not shy to interrupt our speaker during his presentation. So please send us your questions, and we'll get started here with Dr. Compton.
These are my disclosures. I'm a consultant for Tactile Medical. Some of the material was created by myself, and some of the material was provided to me by Tactile. So what is lymphedema? Lymphedema is when the lymphatic system gets overwhelmed by increased hydrostatic pressure, resulting in the leakage of excess interstitial fluid. So this fluid is protein-rich, it's pro-inflammatory, and when it first starts to increase from whatever reason, whether it's a DVT or venous insufficiency or obesity, the lymphatic system can keep up for a while, but eventually the lymphatic system gets overwhelmed, and this protein-rich fluid damages the lymphatic system. And when I first started trying to manage these patients, I would put a lot of effort into differentiating what's the actual source of this edema. The patients like to know why their leg is swollen. And initially, I thought it was important as well for treatment. You know, is it loss of calf muscle pump function? Is it lymphedema? Is it previous DVT? The reality is that any source of chronic edema eventually leads to lymphedema. It's all going to result in that protein-rich fluid overwhelming the lymphatic system and causing inflammation. So we don't necessarily have to definitively determine what caused the problem initially. We can be more focused on how to treat the patient. So many of us, me initially included, associated lymphedema with a cancer diagnosis, either cancer surgery, lymphadenectomy. It turns out that's certainly not the most common form of lymphedema. Worldwide, it's actually a parasitic infection, but in the Western world, in the United States, chronic venous insufficiency is by far the most common cause of lymphedema. So we're seeing a lot more of that these days. Certainly, I'm seeing a lot more of it in my practice, and I would imagine most of you have similar experience. So if you look at the classification of venous insufficiency, the SEEPS classification, you go from C0 all the way to C6. So asymptomatic venous insufficiency, which is only diagnosed with an ultrasound, all the way up to C6 with an active ulcer. And as we progress along that scale, we're going to see a very linear correlation with what's happening on the lymphatic level. The worse the venous insufficiency is, the more damage there is at the lymphatic level as well. And we've got some basic science to back that up. So this is a study where they performed fluorescence lymphography on patients, and they correlated it with where the patient was at clinically with their venous stasis. If you look at the far left, that's a normal, healthy patient, no venous insufficiency. You can see by the fluorescence imaging that there's very orderly, linear progression of lymphatic fluid up the leg. But even when you get to C0, and these are patients that have no outward manifestation of venous insufficiency, they just may have some mild valve dysfunction. But even at C0 of venous insufficiency, we're starting to see some lymphatic dysfunction, pooling of the lymphatics. And as you move your way down the clinical scale of venous insufficiency, when you get to C6 and C5, you see a significant amount of dysfunction in the lymphatic system and lymphatic pooling. So really, lymphedema and venous stasis are not two separate processes. You can't really have one without the other.
Yeah, so Chris, let me just ask you something here.
Sure.
Could you go back to that other slide?
Sure.
So is it linear, meaning that all C3 patients have what we see in this pattern and all C5 patients have this, or is it individualized, meaning that some patients' lymphatics can compensate better than others for the underlying venous insufficiency? Or
Well,
do
I
you
think you're right. You're right. Linear is probably not the best choice of words. I would say proportional. So, as you move down the clinical scale of venous insufficiency, you should see more lymphatic dysfunction. But you're right. I mean, some people have better calf muscle pump function. Some people are walking more. Some people are less obese. So yeah, it's not a one-to-one correlation, but in general, the worse the venous stasis, the worse the lymphedema as
yeah, yeah,
well.
yeah. Okay, good.
Thanks for clarifying that. So, how do we evaluate the patients? Of course, history and physical is the best place to start. It's amazing what you can find out by talking to the patient, examining them. We want to make special, notation of what kind of skin changes we see. Do a pulse exam. It can be very hard to feel pulses in these patients with their edematous extremities. We also want to talk to them about risk factors. Have they had any cancer surgery? Have they had a knee arthroplasty? Anyone in the family have lymphedema? And I've really changed my protocol over the years. Because I have a vascular lab in my office, I would routinely get a venous reflux study and at least an arterial Doppler study to evaluate these patients. Want to make sure they had good enough perfusion to tolerate compression. I want to see if they have any valve dysfunction that could be treated. But over the years, I've kind of streamlined my workup of these patients. I treat them more clinically. So yes, at some point, I'm going to get a venous reflux study because I might be able to do something for them. But if I see a patient in my office who has clinical signs of Phlebolymphedema, I don't necessarily think that they need a venous or arterial study before you initiate treatment. I would feel perfectly comfortable starting them on a pneumatic pump at that point. And lymphoscintigraphy and fluorescence microlymphography, I think it's helpful to see what's happening on a basic science level, helps us understand the process, the pathophysiology. But routinely, I'm not ordering these studies in practice clinically because it doesn't really help me treat the patient. So as I mentioned, I've been seeing a lot more of these patients in my practice, not because I cultivated it. I think just across the board, whether you're a primary care doctor, a physical therapist, or a vascular specialist, we're seeing more and more of these patients in the office. And I have some theories. I mean, one thing's for sure, even before COVID, there's a fairly steady increase in the risk of venous or the incidence of venous thromboembolism. And certainly during COVID, we saw a big spike, but it was well on its way before then. So we're seeing a lot more DVTs, which can certainly cause increased venous pressure in the short term, but can cause damage to the valves and result in venous insufficiency later on.
So Chris, I mean, one of the important things with this, and obviously, chronic venous disease and venous hypertension can be due to, most commonly superficial venous disease, but secondary chronic venous disease from a previous DVT is important because these patients tend to progress much faster. So from a natural history perspective, somebody that has superficial venous disease, it takes years for them to develop, edema, skin damage, versus somebody who has, previous DVT with deep reflux or obstruction. Their venous hypertension is so high that clinically they progress, in
Yes.
6 months, a year, they can have a venous ulcer.
Absolutely.
So early treatment with these, patients with compression and once they start developing clinical symptoms is important because, like I said, their natural history is pretty aggressive or can be aggressive.
Absolutely. And I think this slide will be no surprise to everyone. I think we all know this data. As Americans, we are getting larger, we're getting more obese. And so that no matter what the inciting event is, extra weight increases the pressure on the venous system.
The only thing on that slide, it goes back, it only goes up to 2020. So you don't have the Ozempic dip.
Right. Absolutely. Yeah, the
The cure,
Ozempic,
the cure of obesity is not shown here.
Right.
right. Yeah, that may work out well in the long term.
I'm just
So these are some of the classic external manifestations of lymphedema you're going to see. warty growths on the skin, the kind of thickening and hardening of the skin and the dermis and the subcutaneous from chronic inflammation, weeping, hyperpigmentation. Obviously, it's important to recognize these signs, and it's important to document them because it helps us get the patient's treatment approved. But by the time the patients are manifesting these signs for us, there's some permanent damage that's already been done. So if we're going to do our best for patients, we likely should refer them for treatment prior to manifestation of these signs. So historically, the gold standard for treatment would be complete decongestive therapy. So educate the patients, help them understand why their legs are the way they are, what can they do at home to minimize their symptoms and improve them. It involves some sort of compression, compression socks, manual lymphatic decongestion can work very well. The patients tend to like it and have good success for those that have access to it, but it's hard for the patients to get access. Number one, we have to get it approved, and typically the insurance is only going to approve it for 6 weeks. And a lot of these patients, transportation is a challenge for them. They don't have the luxury of going to doctor's appointments or lymphatic massage appointments twice a week. So if there's something that we can do that they can do themselves in home every single day, that's highly advantageous. We talked about weight loss. Any kind of weight loss for someone who's obese can certainly offload the lymphatic in the venous system. And if they've got venous incompetence, we can certainly offer them an ablation of any incompetent vein, and I think it can help. But if the patient's at the lymphedema stage, especially stage 2, venous ablation alone is not going to be enough. There's going to have to be some adjunctive treatment.
Yeah, and I think that's the point, Chris, that you're making here is that you may want to treat some of the underlying pathology that's causing the lymphedema, but that in and of itself, without treating the, documented lymphedema is just not going to work. So it's not either or, it's really in combination.
Absolutely.
Underlying pathology you treat, whatever that is, plus treating the lymphedema that's the result of the underlying pathology.
Absolutely.
And I was just, earlier you were talking about venous ultrasound and stuff. Obviously, also looking at not just the superficial, like I mentioned earlier, deep venous system, whether it's reflux obstruction below or above the inguinal ligament, because a subset of those patients you might find proximal venous obstruction. But the key here again is how long-standing their venous disease has been going on, and how long have they been in the C3 stage or the Phlebolymphedema. Because long-standing disease, obviously patient expectation after any type of therapy of the venous system has to be realistic that, anywhere from 40 to 60% of those patients may not completely recover their edema.
And Tony, I think you make a very important point that the people listening should understand is that for edema, treating the underlying pathology, in general, I tell patients at best you're going to get improvement by 50%, and you're definitely going to need some other adjunctive therapy, such as pneumatic compression and stuff like that. So, edema, pain, yes. Ulceration, yes. You take care of the underlying pathology, that usually gets better a greater percentage of the time. But edema in and of itself, even though you treat the underlying pathology, you need to set their expectations up front. You're also going to need some adjunctive therapy to take care of your lymphatic issues before you do anything to them.
Now, there was a question about total knee arthroplasty.
Mm-hmm.
What's your feeling of that as far as a risk factor for developing?
I think it's a huge risk factor. It's one of the most common causes of lymphedema, and everyone that undergoes knee arthroplasty is going to have some degree of edema. So that doesn't mean that everyone who gets an arthroplasty needs a lymphatic pump. But if the edema hasn't resolved after 3-4 months, despite physical therapy, I think those patients absolutely would benefit from treatment.
Yeah, I agree.
So with education, the use of pneumatic compression devices is becoming more mainstream, but I think we still have a ways to go in educating people. This is just some data recently from consensus opinions from phlebology and wound ostomy continence nurses. They're advocating now for the use of pneumatic compression devices. And I absolutely agree with that. I might take it a step further. The wound ostomy continence nurse consensus says that they're recommending it for stage 2 lymphedema. I'm going to say I would recommend it for stage 1 lymphedema because if we let them get to stage 2, yes, we can absolutely help them. We can improve them, but they're never going to be normal again. So I think it's great that education is making the use of these pumps more widespread, but I think we have a little more to go on the education side. So this is the lymphedema classification scale, starting at stage 0, minimal or no edema. Stage 1 is going to start out, it's reversible. So it's typically pitting edema. The patients will report that when they wake up in the morning, their leg looks pretty normal. But as the day goes on, the end of the day, they have a lot more swelling. And it's this kind of cycle. And so at this stage, it's very treatable. And there's really no permanent damage or minimal permanent damage to the tissue and lymphatic system. But once they get to stage 2, where it's no longer pitting edema, you have the hyperkeratosis and the induration. Unfortunately, even with best treatment, they'll probably never be normal again. Yes, we can absolutely improve it. We can cut down their risk of ulceration. We can cut down their risk of hospitalization and infection. But if we're going to do our best for the patients, we probably should be referring them for treatment prior to stage 2. Of course, stage 3 is elephantiasis. We do see that in the United States. And yes, it's a bad position to be in, but it is something that we can improve with lymphatic pumps. So goals of therapy, a big part of this is lifestyle. I mean, if someone's got a weeping ulcer and they're having to go to doctor's offices or therapist's office 3 times a week, it's not a good lifestyle. The stretching and the tearing of the skin can be very painful. They have a high risk of cellulitis, and we'll see some data for that, and high risk of hospitalization. All these things contribute to a poor lifestyle. So if we can improve on that, then it will be a huge benefit to the patient. This is from a recent study, Journal of Vascular Surgery, 2024. Phlebolymphedema has a much higher morbidity rate than cancer-related lymphedema. So if you look at breast cancer-related lymphedema, gynecologic cancer-related lymphedema, those patients have much lower risk of cellulitis, much lower healthcare costs than the phlebolymphedema patients. And so I think this reinforces what you gentlemen were saying. These patients that have bad venous stasis, we need to be a little bit more aggressive about those patients because their long-term outlook is potentially fairly poor.
And the important thing, go back one, Chris. The important thing with this, with cellulitis, these patients, once they develop cellulitis, their lymphedema gets worse.
Yep.
Every episode that follows, obviously, just compounds things. So early, like you said, early treatment of them, controlling their edema, education, skin care, all these things to reduce their chance of getting cellulitis is critical. And really, when you look at the literature, FlexiTouch is really the only pump out there that has any data showing that use of pneumatic compression with an advanced pump reduces cellulitis episodes as well as hospital admissions and healthcare costs.
Sure. Yeah, we've got some data on these slides to support exactly that. So, as a vascular surgeon, I considered my civic duty to take care of these patients. I felt like I had the tools, at my disposal. I've got wound care supplies in the office. I've got a vascular lab. I felt like I was as well equipped as anyone to take care of these patients. But the reality is I actually kind of dreaded seeing them for the longest time. I felt like I didn't have a good long-term solution for them. Surgeons, we like to see things that we can fix. And I felt, at best, I was, putting a Band-Aid on the situation. If they had an ulcer, I could get it healed, get them in compression dressings, but I didn't feel like I had a good long-term solution. I felt that as soon as I released them back home, they were just going to go back into this cycle of recurrent cellulitis, doctor's visits, wound care, et cetera, et cetera, et cetera. But since working with Tactile, I mean, I have a lot greater sense of optimism because I think this is a good long-term solution for patients. So Tactile makes two different pneumatic pumps. The first one is the Nimble. It's considered a basic pneumatic compression device. It's actually very easy to use. It's just one zipper on each side. It's very streamlined. It's very minimal in terms of its footprint. It's got a little power box which weighs less than 2 pounds, so patients can actually travel with this pump. The FlexiTouch is the more advanced pump. It's somewhat unique in that it's got a central decongestion with a waist attachment. So it's going to be better for people that have that truncal edema or more proximal edema. So the basic pump, the Nimble, has 8 chambers that sequentially inflate to decompress from distal to proximal. And you can see our patient lying on the sofa there. It's pretty minimal what you have there as far as hardware. And I think, at least in my practice, a lot of my patients are elderly, they're retired, they like to travel. And a lot of times we'll get them in a good position with their pneumatic pump. We'll get all their ulcers healed. The skin will be looking good. And they'll go away for a few weeks or go away for the summer. They don't bring their pump because it's cumbersome and they don't want to travel with it. Then they have a setback. They show up in my office 4 weeks later with an ulcer and we're kind of starting from scratch. But with the Nimble, I think it's very easy for them to take it with them, either in the car or in the suitcase. And that way they don't miss any of their treatment. This is just a slide showing what the basic pump is capable of pressure-wise. There's different settings. So, if a patient has a very large, painful, swollen leg, we can start in a lower setting, but we're capable of producing pressures up to 60 millimeters of mercury, which is pretty substantial. But the nice thing is it's intermittent. So it's not like putting an Uniboot on a patient. It's not going to put them at risk of tissue loss if they've got some peripheral arterial disease. It's very well tolerated.
Hey, Chris,
Yeah.
since you mentioned on PAD, what do you tell patients, or what do you do with patients who have, underlying PAD or low ABIs baseline as far as compression? And do you have any clinical criteria as far as when you put them in a pump?
Yes. So clinically, if they don't have critical limb ischemia, I'm more than comfortable putting them in an intermittent pneumatic compression device. So, if someone's got claudication, I think an intermittent pneumatic compression device would be fine. I wouldn't put them in an Uniboot. I'd be a little worried about that. Now, if somebody's got ischemic rest pain or foot ulcers or gangrene, I'm going to, obviously assess their vasculature and most likely revascularize them.
I mean, obviously, the pump is great and it's in the whole picture of treating these patients, but on top of that, there needs to be some type of static compression, the rest of the day. So do you have a cutoff as far as ABIs and putting them in static compression, or?
I mean, I'll put them in static compression depending on what the ABIs are. If it's 0.5 or so, I feel completely comfortable putting them in light compression.
Mhm.
How do you guys feel?
Steve,
No, I mean, I agree with you. And I think Tony brings up a point that people should understand that it's not you use the pump and then you wake up in the morning and you go about your day without any kind of compression on on your legs. I mean, the pump is getting rid of the excess fluid and you use it at night because that's when you're going to be, recumbent and less chance of fluid reaccumulating. And then during the day, you're wearing some type of compression to minimize the recurrence. And I liken it, I say to patients, it's like wringing out a sponge. You know, it's not a one-time thing. You keep squeezing, squeezing, it gets drier, 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 and you don't want the water to come back, and that's why you need to wear your compression stockings, or whatever, during the day. So the pump gets the water out, the stockings prevent some of it from reaccumulating, and over the course of weeks or months, you're going to slowly, get your leg less and less edematous. And they need to buy into that. It's one or the other doesn't work. The two together is really the optimal.
Yeah.
Good point.
And the other thing is, um, lost my train of thought now. Sorry.
The ABIs that you feel comfortable with compression?
No, no, no. It'll come to me.
Yep.
Another question. Contraindication of pumps in acute DVT? And when do you start, is there a time period after the
Yeah, so a
before you
different
get,
different physicians have different comfort levels. The other question that goes along with that is how soon after an endovenous ablation would you allow a patient to use the pump? So I let my patients use the pump a week after endovenous ablation, not because I'm concerned of embolization. I just kind of want that clot to sit there for a while and make sure it's doing its job. I know some surgeons let people use a pneumatic pump immediately after endovenous ablation. So that's a little different for me, but I think, everyone's got a little different threshold. As far as DVT goes, I would feel absolutely comfortable if the patient's been properly treated, using it a month after, and I think even less than that would be reasonable.
okay.
Well, also, you're pointing out here what the pressures are. I mean, we're not talking about like 120 millimeters of mercury pressure that you're going to like really it. Why don't you explain to them that this is not like how can I say it? It's not like compression that you're thinking of in terms of a hard, a lot of strength. This is the lymphatics move the fluid differently than the veins move the fluid. And I mean, your pressures here are not so high as they're going to squeeze a clot and make it go up to the harder lungs.
Right.
And Steve makes a point. I mean, it's the same thing when people had DVTs in the old days, they get admitted and stay in the hospital in bed rest because the concern of, the pressure, of embolization if they're walking around. The
Right.
pressure that the calf muscle pump when you walk is way over 150 millimeters of mercury. Um, and we tell patients walk right after, we don't tell them you need to stay in bed because so I understand your point, Chris, maybe waiting a little bit, but that's based on our concerns really. And the IFU that says that, it's a contraindication in acute DVT. But the reality is, if you look at, if we're telling patients to walk, then there's no reason theoretically you can't even put a pump on them if they're
Right.
treated.
I
And to,
agree.
and to the same point after endovenous ablation, or whatever, it's the same deal. We don't tell them not to walk after endovenous ablation. We want
Right.
we
Yeah.
want them to walk. I think, this is left over from the past, and we need to kind of
The thing, Steve, I just remember lost my train of thought
go ahead.
about static compression and compression size. So for those in the audience that may not know yet, but the Lymphedema Care Act, the great thing about recent Congress passing um, is that Medicare patients now get full coverage for compression socks or wraps every 6 months. So obviously not that it's only in Medicare patients, but at least in Medicare patients, there's coverage for treating these patients with static compression.
Good point.
Good point.
Go ahead there, Chris.
All right, so the Flexi Touch is more advanced. Instead of 8 chambers, it has 32. It provides a little more opportunity for programmability, so you can program it by section. You can do the foot and the calf and the thigh separately, separate pressures. So if the patient has an area that needs a little more attention, maybe a little more pressure, you can program it that way. If they have an area that's a little more sensitive, you can decrease the pressure in that area. And as I mentioned, it's unique in that kind of central or truncal decongestion that it performs.
And Chris, actually, sorry for interrupting you again, but there was a
No,
question
Tony,
about,
you're okay to interrupt. We said we're going to interrupt. Don't
yeah,
worry.
there's a question patients with fragile skin and tenderness, do they tolerate the pump? And you just actually answer that with adjusting the pressure in these patients, not just lower, but also higher in patients who have fibrotic skin and you want to soften it.
Yep. Yeah, and sometimes people, especially if they've got acute ulcer, acute tear in the skin, it can be very sensitive. But I try to reinforce with them, listen, we can't get this to heal until we get the pressure out of your leg. So even if you could do 15 minutes with the pump to start, let's get the process going. And over time, you'll be able to tolerate more.
So, yeah, let me ask you this. When do you go directly to FlexiTouch and when do you start with the basic pump nimble? In other words, let's give some guidance to the people that are listening. When is it that you're going to write FlexiTouch off the bat? And when is it you're going to write nimble off the bat?
Well, so the one category where FlexiTouch is a clear winner is those with truncal edema or the more proximal edema. So I'm going to try to go to FlexiTouch initially on those. Some of it's dictated by insurance. I mean, Medicare, for example, we usually have to try the basic pump first before we can even get a FlexiTouch. And then people that are very sensitive, they'll quite commonly tolerate the FlexiTouch more than the basic pump. But those that want to use it to travel, certainly the Nimble is definitely better in that situation.
All right, good.
So this is just the numbers for the pressures on the FlexiTouch, similar in maximal pressure to the Nimble, but a little bit more programmable. And to talk about my experience with pneumatic pumps, it's probably been about 8 or 10 years I've been prescribing them. Initially, I worked with a company that was different than Tactile, and I had a moderate amount of success with their pumps. Certainly better than static compression alone. But the way it worked with that company is I would just make the referral for the pump. Sometimes we would get it approved, sometimes we wouldn't. And I didn't really get any feedback, but I started using a Tactile probably about 5-6 years ago. And, I did find that their product was superior, but probably equally as important, when you work with Tactile, you have a team. And we rely very heavily on our Tactile reps. Our patients love them. The ladies that run my office typically don't like having reps in the office, but we all like having our Tactile reps because they really facilitate the patients getting the care they need. And it really unburdens me because they're handling most of the questions and the troubleshooting and whatnot once the patient gets the pump. So, I mean, the Tactile team is something that is, really to be spoken highly of.
Yeah, and I mean, make that point a little bit more in depth in terms of what the team is helping, and people who are listening should understand this, is that the team is there not just to bring, lunch to your people that are working for you, but they're really there to make sure that what's needed for insurance purposes and for coverage and stuff is in the chart, is in the history and physical and stuff like that. And I'm assuming that's what you're talking about, is how much
Yeah.
they help with documentation because they
Yep.
know what's needed.
They help us with the templates and documenting what we need. They help us with the follow-up. If I have a patient on my schedule that I know I referred for a pump, if the Tactile reps have not given me a list of the patients I'm seeing that day and where we stand, I mean, typically they make a list for me. Oh, Mr. So-and-so, pump shipped this date. Mrs. So-and-so, waiting for off, we're appealing. Mrs. So-and-so, been
Yeah.
using her basic pump for a month. And if I get a patient in the office and I say, hey, how's it going with the pump? Most of the time the patients are very happy, but occasionally they'll say, listen, I've been using it for 2 months. I haven't seen any difference. And I text the rep and say, hey, listen, Mrs. So-and-so is not seeing any improvement. Can you do a reprogram for them? They're saying, absolutely, no problem. I call the Tactile reps or text them very frequently, and they're very helpful at facilitating the patients getting the care that they need. And I mean, I should mention, I think it's fairly unique that Tactile sends somebody out to the patient's house to show them how to use it. That really, helps them get hooked up and minimizes me getting phone calls. So I'm very appreciative of that.
Yes. Good points.
So there was a couple of questions in here about what pressure do you adjust to in patients who have areas of fibrosis or lobules. So as you can see here in the table, we usually adjust it to the increased pressure rather than the normal pressure that the pump is pre-programmed at. And again, you can adjust this so that specific area where the fibrosis is only the only area that's at increased pressure.
Yep.
Right. We have another slide, Chris?
That's yeah, I've got a couple more. Yeah. So I think we've kind of covered this. So FlexiTouch can absolutely help with wound healing, and the patients can definitely use it over their bandages. So if they've got an Unu boot or 4-layer compression, I don't let that slow us down. I initiate the lymphatic pump right over the dressings.
There was a question, either one of you guys. Patient with CVI lymphedema, venous reflex ultrasound shows has chronic DVT in his right leg. So can this patient use a pump and wear daily compression?
Absolutely on both. I mean, this is a patient that would really benefit from a pump, and there's no safety concern, and absolutely it's going to help offload the lymphatic system.
Right. And first of all, there's no such thing as chronic DVT. You mean
Thank you.
post-thrombotic changes. Because we don't want people to think like, oh, there's a DVT, I can't use the pump. It's post-thrombotic changes. And I agree. These are the patients that benefit. I mean, because we don't have, for infrainguinal post-thrombotic venous disease, we don't have that many invasive options. I mean, and there's a couple of things that Tony and I do, but in general, people don't. And really, the pneumatic compression pumps are really the mainstay of managing their Phlebolymphedema.
Yeah, and these are, like I mentioned earlier, these are the patients probably that benefit the most as far as getting them into
Definitely.
compression early.
Definitely.
Opinion on vascular stents and use of compression or pumps? Not quite.
So I think, most of the time in the lower extremity, it's going to be a self-expanding stent. And as Dr. Elias mentioned, these pumps usually are not enough pressure to occlude a stent.
You're talking, Tony, you're talking about arterial stents, you're talking about venous stents in the iliac system.
I'm going to assume they're talking about venous.
Yeah, so in other words,
Doesn't matter. Regardless, I think,
right,
Chris's point is
exactly,
on par.
right.
Yeah, so no contraindication with stents. This is a study from the Journal of Vascular Surgery, and what they did is they took patients with a diagnosis of chronic venous insufficiency and lymphedema, so our Phlebolymphedema patients, and looked at the course of their prospective follow-up, what kind of impact conservative management for lymphedema versus a basic pump versus advanced pump had on their healthcare dollar spending. And so, as you can see, if you look on the left, you see conservative therapy. So that's going to be our static compression, our massage, our education, our elevation, compared to conservative therapy and FlexiTouch. Very significant reduction in healthcare costs per year. Same thing for, conservative with a basic pump. Conservative with FlexiTouch advanced pump use has a dramatic reduction in healthcare expenditure over the course of the year. And even FlexiTouch compared to other brands of advanced pump, you can see the final columns on the right, 53% reduction in healthcare expenditures for FlexiTouch compared to other advanced pumps. And this is because, it's decreased hospital visits, decreased hospital admissions, decreased cellulitis episodes, decreased trips to the doctor for wound care. So lymphatic pump can have a dramatic reduction in our healthcare expenditure in these patients.
There's a question on, and I don't know, Chris, if you have experience with lymphedema. Do you see these patients? Do you use pumps with them? If so, what?
I do use pumps with them, and I think it can be of benefit. I'm not a world expert in lipedema, but I think if it's truly lipedema, then I think the pneumatic pumps can be very beneficial.
Yeah, let me ask you this, what we all think about this. We know there are certain clinical situations where the patient has a higher chance of developing lymphedema, whether it's Phlebolymphedema or lymphedema. And we already spoke about that, the total knee people and stuff. Chris, what do you think about instituting in a prophylactic sense some type of pump therapy in these patients to minimize their developing edema post procedure?
I think you bring a great point. I think especially the arthroplasty patients, I think it would really be beneficial to those patients to start with the lymphatic pump immediately post-op. I think we could really cut down the risk of permanent lymphedema
And
changes.
it's not just a permanent damage. The more swollen their leg is, the harder it is for them to ambulate and for them to go ahead with physical therapy. So it might be an area of
Research.
research to
Yeah.
look to see, you institute prophylactic treatment versus you don't, and who gets back to ambulating or whatever sooner than somebody else, whatever the metrics
So,
would be.
so
I
you
do
obviously in those patients, Steve, it's either their Phlebolymphedema is either because, or the lymphedema is either because of Phlebolymphedema from maybe an undiagnosed DVT or something, and
Right.
they come back, a couple of years later with a big swollen leg that they've had, and they had a DVT they didn't even know about, or they had a DVT they knew about, or it's due to the surgery itself.
Correct.
And, the question is, I think you bring a very good point, as Chris mentioned, an incision over the knee, is it really destroying the lymphatics?
Hmm.
Or is it the post-surgical swelling that overwhelms the lymphatics that may be somewhat compromised to start with, and it's a second hit that, you know, tips them over the edge, and then their lymphatics cannot recover. So prophylactically treating them may help them, prevent them from developing long-standing lymphedema.
I think the other category of patients that might benefit is patients with acute or subacute iliofemoral DVT that can't be reconstructed. Those patients have a high risk of stasis later on in life. So if I see a patient like that, if they can't be reconstructed, or maybe they're out of the window where they can be reconstructed, I'm going to try to get them in a pump.
Yeah, sometimes the trouble is, getting it covered and stuff. Can you give us some pearls and the people that are listening regarding what are the things you really need to document? And I know our tactile reps make sure we document everything, but give them some of the things like, in your history and your physical that you need to document regarding coverage.
So yeah, I mean, use of conservative therapy like compression socks, elevation, that sort of thing is very helpful to get approved. And also the skin changes. So typically edema is not enough. You have to document the hyperkeratosis, the secondary skin changes to get the pump covered.
Yeah, yeah. I think people need to do that. And if you're going to get into this, which obviously we all feel that you should, you can rely on your tactile reps to let you know exactly what you need to document so that the insurance, you get coverage at your first go around rather than having to, do it again.
I want to,
Go
Steve,
ahead.
I just want to reiterate, because I know there was a couple of questions earlier about DVT and pump use, and the IFU does have acute DVT as a contraindication for
Right.
using a lymphatic pump, but in the acute phase, I personally don't think it's a contraindication, but you know, because of the IFU, we don't use it at least the first month.
Right.
Um, and just to reiterate the chronic DVT comment, because that's not just at this webinar. I mean, almost every educational program we do, somebody calls it chronic DVT. And this is really, just to reiterate, it's scar tissue in the vein that leads to obstruction or reflux and venous disease. So There is no contraindication in using a pump in these patients. If anything, you should be using
Right.
a pump in these patients. There was a question on lymphedema therapists. When do you send, you see a patient, do you send those patients? Do you set them up with lymphedema therapy? How easy is it to get it set up? If you can comment, Chris, as far as
Sure. I
the
think
duration of
lymphedema,
therapy, these patients are, covered with their insurance. So,
yeah, I think lymphedema massage therapy is an excellent tool. I think that, 80% of patients are going to benefit from it. At least in Tucson, the number of people that have that expertise and that can do that for patients is we only have one or two in town. So it's hard for us to get our patients in to see them. Some other towns are probably different. If you've got access to people with the expertise who can do that, then I think it's a great treatment modality. And I think, patients do like it. I mean, if they have the wherewithal to get to the appointments, I mean, who doesn't like a massage, and it works. They feel like they're getting taken care of. So I think it's a good thing to prescribe if you have access to it. But eventually, the insurance isn't going to cover it. So, we're going to need something to take over for the patient after that point.
so the other thing I wanted to bring up, since this topic is Phlebolymphedema today, and you know, one of the things I wanted to cover is actually a recent paper that was published in, and so this is a paper that was just published on lymphedema patient experience, and it's looking at almost 2,000 patients globally, and they've asked 23 questions, anything from demographics to diagnosis of symptoms, treatment, and what they found was basically there was, not surprisingly, huge delays in diagnosis from onset of symptoms as well as start of initiation of therapy. And you can see here, they broke it down in cancer-related lymphedema and non-cancer-related lymphedema. And you can see in the cancer patients, 60+% of the patients were diagnosed within the first 3 months, which is, a nice amount. But again, 40% of them, it took more than 3 months. And these are cancer patients where the suspicion or the chance of getting lymphedema after therapy or surgery is pretty high. So
Mhm.
even though recognizing that as a risk factor of developing lymphedema, it's still 40% of them took more than 3 months to be diagnosed after symptoms. And if you look at the non-cancer patients, more than 60% of the patients were diagnosed after 12 months. So there's a huge, especially for the non-cancer, so Phlebolymphedema patients, more than a year from when their symptoms develop to when they get diagnosis. When they looked at some other variables, such as, how many physicians they saw, you can see 80% of the non-cancer patients saw more than one doctor before they get the diagnosis. And you can see here, 30% of them saw 5 or more physicians before they had a diagnosis. Interestingly, even in the cancer-related group of patients, the majority of them were diagnosed, like 60% of them were diagnosed by non-cancer physicians, so their primary care or another specialist. And then the time, sorry, and from the time between symptoms and therapy, you can see here 70% of cancer-related patients received treatment within the first 6 months. Obviously, they were diagnosed earlier, but more than 65% of the patients waited over a year before they were put anything, compression, pump, or whatever. So obviously, significantly under-recognized, especially the non-cancer lymphedema, and obviously Phlebolymphedema falls in this category,
Right.
which is why I wanted to share this with you guys.
Yeah, I mean, look, it's just about increasing awareness among, and I think that study makes the point, increasing awareness amongst the primary care physicians that A, you should try to make the diagnosis, and B, there's good therapy for it. And the earlier therapy is instituted, the better the results of the patients. Remember, most of these primary care physicians, unfortunately, the way our system works, they're very busy. They're just trying to get through their patients, and a little leg swelling is not the biggest thing on their mind. They're looking to save people's lives with whatever heart disease or anything else they can identify, which is unfortunate because we all know this is a significant effect on patients' quality of life, as you said, Chris, to walk around with a swollen leg. And I guarantee you, once a primary care physician has either him or herself or one of a family member has edema and they get a pump and things go well, they're going to refer patients sooner in their practice than later. But
Just want to, Steve, add a comment from one of the probably one of the therapists that is watching with our total knee discussion earlier. They work with a orthopedic surgeon who actually refers their patients for therapy to reduce risk of edema after total knee. And the nice thing she says is that the patient's already set up for therapy even after surgery.
yeah, they refer it beforehand.
Yeah, before their surgery.
No, that makes sense because many of us know we see people who have leg swelling. They haven't had knee surgery, but they have knee problems,
Yep.
and because of their inability to ambulate that well, they get this dependent edema. So that sounds like a good orthopedist.
Yeah. And the other comment from one of the therapists, just to share, and I agree, is um, getting these patients, once they are hooked up with their lymphedema therapy, to continue, therapy. Obviously, like we mentioned, it's not covered by insurance forever. With self-film LD. Now, not all patients would be candidates for or compliant with that, but that's an important point too.
Yeah. Well, all right. Very, very good, Chris. You brought us up to date with Phlebolymphedema.
Thank you.
Oh wow, another therapist. My orthopedic surgeon will not do surgery until they get lymphedema down before surgery.
All right.
So it
These
sounds
are,
like Tactile needs to do some type of study here to,
yeah, with the orthopods.
yeah. All right, so I want to wrap up here. I think we got all our questions taken care of, and we're almost up to time. I want to thank Chris for excellent presentation. Really, the audience for being very interactive and a lot of questions, and obviously Tactile. And also Dr. Elias for pinch hitting in the last minute since our other moderator or speaker
That's right.
not
Anytime.
available.
Happy to help.
Thank you, Tactile, for putting this together, and I hope everybody has a good evening.
Yeah,
And
nice
see you
meeting
at
you,
the next
Steve.
Yeah, take care, Chris. Thanks. Same thing here.